welcome everyone today to the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Is today Tuesday or Wednesday? Which day is it, Carol? I don't even know anymore. It's Tuesday. Okay, yeah. I was hoping it was Wednesday, but okay. Sorry guys, my days are running together. So today is Tuesday, November the 15th. So welcome everyone from joining. Let's see, on the panel today from the STS side, we have myself and Carol Crone. We have Emily, and we have Chastity from the core group. From our STS surgeon leadership, we have Dr. Meyer, and Dr. Subramanian will be joining us here in a little bit. And then from our IQVIA team, we have Joe and Melanie. So thank you everyone for joining today. I just have some brief STS updates, not a lot of new information from our last call. I know we just had a call a couple of weeks ago, so not a lot of new information from me. Then we'll turn things over to Chastity for some STS education. IQVIA will provide a brief update, and then as usual, we'll finish off with your user feedback. If you have any questions, please feel free to put those into the Q&A. Also, you can use the raise hand function if you prefer. So just make sure your microphone is enabled and we'll unmute you for your questions. All right, STS updates. November training manual is available. It's posted out on the STS website. Again, the 2022 harvest, we are expecting those reports to be available next month. And just a reminder that the updated stat scores, again, were implemented into that analysis. We are currently in the process of UAT testing the data in the IQVIA platform. So once that is complete, we will get moving forward with getting those results pushed out to you all. As always, participants will be notified once the data is available within the IQVIA platform. The 2023 harvest, all of the 2023 harvest dates have been posted out on the STS website, so those are available if you would like to go out and check that information. The spring 23 harvest is scheduled to close on March the 10th, and that does include a reporting period of January 1, 2019 through 12/31 of 2022. And the fall 23 harvest is scheduled to close on September the 15th, with that reporting period of July 1, 2019 through 6/30/2023. If you're not familiar with where the harvest schedules are posted, if you go out from the STS homepage, sts.org, click on the registry's STS National Database, and scroll down the page here under important resources, harvest schedule and information, click here, and the harvest schedule for all of our databases are posted here, all of the 2023 harvest schedules for adult cardiac, general thoracic, as well as congenital. Just scroll all the way down to the bottom for congenital. All right. In regards to the data version 6.23.2, the go live date, as you're all aware, is scheduled for July 1 of 2023. And I am finalizing the data collection form, and that will be posted and available on the STS website next week. We will send a notification, out, have marketing send a notification out once that document is posted and available. Also, that notification will include the official go live date for July 1 of 2023. So look for that next week. Also, again, just a quick reminder for those of you that were not able to join us on our last call, thank you for all of you that were able to attend AQO. Just a reminder that the live sessions were recorded and will be will be available for viewing this month. I think we are looking at hoping to have all of that content available for you next week. And all content will remain on the AQO platform until October the 28th of 2023. Once those live sessions, the recordings of those live sessions are available, STS will be reaching out to you all, to all of our virtual attendees, as well as all of our attendees, to let you know that that content is available and out on the website. Also, we are planning to have that AQO Hot Topics webinar will be held in January. We'll be bringing back our speakers in order for our attendees to ask questions. I believe we haven't set the congenital date yet, but we are looking at the week of, I think it's January 9th, Carol. I think that's what we were talking about. Yes, so, yep, tentatively mark on your calendar. The week of January 9th, we'll have one session for the congenital group, and again, as soon as I get that date scheduled down, I will let you all know. Continuing education credit, just a reminder that attendees must watch all of the on-demand content and live content, then evaluate all of the presentations. Certificates will be processed once a month based on the prior month's completions, and your deadline to complete evaluations and claim that credit is January 28th of 2023. Also, since post AQO, we have had some interest in participating, some persons wanting to purchase the virtual component that did not purchase prior to the registration close. So if you are interested in purchasing the virtual component, we will be selling the virtual component. So that will be coming back. So if you are interested in purchasing that virtual component, STS will be sending out information on the virtual component and being able to purchase that. And I believe they're hoping to get that information out next week. So if you did not purchase virtual component and are interested, there is still opportunity to view AQO 2022. That's all that I have from STS side. I see a couple of questions, but let's go ahead and move on with Chastity Education, and then we'll tackle questions once you have done your case review.
Okay, sounds good.
Mm-hmm.
Next slide.
Yep.
Next slide.
I'm on it. I need more coffee.
Thank you, Vanna. Okay, so I thought we would kind of wrap up AQO. I know we have the upcoming Hot Topics from AQO webinar in January scheduled. So I didn't want to give any updates from AQO since everything will be done on that platform. So I thought I would do just a case scenario, which I think flows with AQO agenda. And this will be for those of you who've been doing this for a long time. Hopefully it will, maybe spark some things to think about. And for those of you who are new, hopefully it will, kind of help with your train of thought as you're coding some complex cases. So patient background here, the patient transfers to a surgical hospital post-birth, and they had a prenatal diagnosis of hypoplastic left heart syndrome with aortic and mitral atresia. Next slide. So this patient is born at 37 weeks gestation, and the clinicians continue to document throughout the medical record as this is a late preterm patient. So when you're now coding into the database, how will you answer field 350 premature? So would you say yes, or would you say no? I know we don't have polling questions open, but just think about your answer. I'll give you a few seconds, and then we'll discuss what the correct answer is. So again, the patient was born at 37 weeks gestation, and your clinicians continue to document this as late preterm. All right, next slide, Liam. So if you look in the training manual at our definition, you will see that it says indicate whether the patient was born prematurely as defined by a gestational period of less than 37 weeks. So anybody that has completed 37 weeks of gestation then is not considered to be premature. So I think this is one probably very minute scenario where your clinicians may be documenting something clinically, as in early or late preterm birth, but that does not mean by the STS database definition, and all of us are held to the same definition for consistency upon analysis, that this patient is premature. So even though your clinicians are dictating or documenting someone is preterm or late preterm, we have to follow the definitions of the database. So we would correctly say no in this scenario. Next. So the patient required intubation following delivery and for safe transport, and then was immediately extubated upon arrival to the surgical hospital. So how would you code is preoperative factor 470, mechanical ventilation to treat respiratory failure, applicable in this scenario? So again, the patient required intubation at birth for safe delivery or safe transport, and then was extubated immediately upon arrival to your surgical hospital. So would you go into your pre-op factors and code yes, or would you code no? All right, Leanne, let's go to the next slide. Okay, so in this scenario, you would say no, because if you look at the definition in the training manual, the patient was supported with mechanical ventilation to treat cardiorespiratory failure. So again, this patient required intubation following delivery for safe transport. And so this was not for cardiorespiratory failure. And it also requires the mechanical ventilation to be at your hospitalization or during the hospitalization of this operation. So at the surgical hospital. And in this scenario, the patient was extubated upon arrival to that surgical hospital. So this patient does not meet the criteria for the preoperative factor 470 mechanical ventilation to treat respiratory failure. Next slide. Patient required a bedside septostomy. The patient was intubated for the procedure and then remained intubated for a cardiac MRI the following morning. So now is preoperative factor 470 mechanical ventilation to treat respiratory failure applicable? Yes or no? Next slide, Leanne. The answer again is no. So we're looking for the fact that the patient had cardiorespiratory failure that required the mechanical ventilatory support. And this patient was electively intubated for the septostomy and remained electively intubated for the cardiac MR the following day. And if you've astutely read the training manual, as I know many of you do every month, you will notice that there was a question that was asked to us in the last few months about the time frame for an elective intubation, 24 hours, 48 hours, whatever, maybe between procedures. And the answer is there is no time frame. If the mechanical ventilation is elective, it's elective, and it's not for cardiorespiratory failure. So next slide. How would you then determine if the mechanical ventilation is elective or not? If you're just looking at the fact that a patient is on mechanical ventilation, say in a respiratory therapy flow sheet or in the nursing flow sheet, you just see that the patient is intubated or requiring mechanical ventilation. But how do you know whether that is elective or not elective? And so the best places to look for this is reviewing your clinical documentation for a plan of care. So sometimes perhaps an ICU note or the procedure list doing, the specific procedures may say we're intubating this patient electively for this procedure or that procedure. Or while the patient can extubate or would extubate otherwise, we're going to just go ahead and leave them intubated because the cardiac MRI is first thing in the morning. And so you got to be looking for kind of those buzzwords and such. If you see things like patient could not extubate, cannot wean the ventilator, and those kinds of words, then you're going the other way, that this patient likely has then cardiorespiratory failure. If you can't find anything documented, this is a great time to talk with your clinical team to ask, was this patient, did they require the support, or is it something that we did electively overnight for comfort or just good, patient care? And then talk to them. This is a great opportunity to talk to them about documentation of the plans, because it will decrease the amount of emails or perhaps meetings that you need to schedule with your clinicians, which I know mine appreciate that. And especially if you can get on to, fellows and things like that, they're really good at documenting and like to make you happy. And so if you can work with them to increase their documentation, that is often very helpful as well. Next slide. So the genetic notes state that there is suspected Noonan syndrome. So a chromosomal microarray is sent with additional genetic tests that were sent to an outside lab. So how will you now code the chromosomal abnormalities and the syndromes? So is it the first checkbox, code syndrome 350 Noonan syndrome, given the genetic team's suspicion and documentation? Or leave syndrome and chromosomal abnormalities blank until the genetic testing results are received? Or code syndrome 5, no syndromic abnormality identified? Give you a few seconds to think about it. Okay, next slide. I'm hoping that all of you said leave the syndrome and chromosomal abnormality fields blank until your genetic testing results are received. So I caution you not to answer or code fields until you have the information. I know many people like to employ things called, maybe placeholder documentation until something comes back. So maybe you want to say no or yes until you actually, receive the results. However, especially when volumes get big and cases get busy and such, you can no longer keep track of, or perhaps you're tracking in a separate tool, a spreadsheet or something, of what has a placeholder answer versus what has a real answer. I personally train my team to never do that. Leave it blank if you don't know, or if you're waiting for something to result, that's absolutely fine, because otherwise we could potentially send out data, submit data to third parties, or perhaps in presentations around the hospital and things, and we're not giving out the most accurate information because it's just a placeholder or an incorrectly coded field until we actually have the results. So I would rather have a blank field until I for sure know what the results are than to have something incorrectly identified as either yes or no in the database. So that's just kind of my 2 cents of data collection, and don't think using placeholder data is a really good idea. Next slide. Due to low birth weight and late preterm birth, the surgical plan is to place bilateral pulmonary artery bands. The patient arrives into the OR on a continuous PGE infusion. So which procedure will you code for the bilateral PA band placement? Will you code procedure 2160, hybrid approach stage 1, application of right and left PA bands? Or will you code procedure 2180, hybrid approach stage 1, stent placements in the arterial duct, plus application of right and left PA bands? Or will you code procedure 1640, PA banding? So take a few seconds to think this over. All right, Leanne, next slide. So the correct answer here is coding 2160, hybrid approach stage 1, application of right and left PA bands. And let's discuss this a little bit on the next slide, Leanne. So I put in the current definitions of both 2160, the hybrid approach stage 1, application of right and left PA bands, versus the definition for 1640 PA banding. And if you recall earlier this year, we clarified these 2 terms. And so if you're going to use the hybrid approach stage 1, this is for the application of bilateral pulmonary artery bands with either a ductal stent to maintain patency or concomitant use of PGE to maintain ductal dependency. Versus 1640 is placement of a pulmonary artery band any type, may include a unilateral PA band, a main PA band, or bilateral PA bands without the concomitant use of PGE to maintain, or a stent to maintain that ductal patency. So in this scenario, 2160 is the correct answer because the patient is on PGE to maintain their ductal patency, and the bilateral PA bands were applied. So that is how we would make that decision. This is spelled out very clearly in multiple places in the training manual, but if you have questions, obviously we would want you to submit your specific scenario or question to the core group. Next slide. So the patient extubated on post-op day 4 was weaned off inotropes by post-op day 10, but returned to the OR for a Norwood procedure. Is the Norwood procedure a reoperation during this admission? This is referring to not the complication of reoperation, but the field 1087 reop during this admission. So is the answer no? Or would you answer yes, planned reoperation, yes, unplanned reoperation, or is there not enough information available to determine? All right, Leanne, next slide. So the correct answer is you don't have enough information available at this time to determine. What I gave you is not enough information for you to determine if this was a planned or unplanned reop. It is a reop, so no is completely wrong, but was it planned or unplanned becomes a new decision tree for you. So if you go to the next slide, Leanne, how do you determine if a reoperation is planned versus unplanned? So you really have to review the clinical documentation or surgical plan of care surrounding that index operation. It should be clearly documented what the plan is for your patient. And so this Norwood procedure could have been a part of the original surgical plan. Remember, this patient was late preterm and had low birth weight. And so was the plan to allow the baby to grow to 3.5 kilos, and then they were going to perform the Norwood anyway? Or was the plan to go down the hybrid route and really move on to a hybrid stage 2, but ultimately they failed their initial hybrid palliation and required the Norwood procedure? So you really are going to have to, figure out what the documented surgical plan is at the time of the index operation. I know, even in my own experience, this can be very difficult to elicit. And when you go to your surgeons and say, was this planned? I know the answer might be yes. And so I think it's, really working with your teams to help with documentation and understand what's going on. I often find the best surgical plans come from our surgical PAs or even the ICU. They document the surgical plan because they need to know, they're the ones with the patients all day, every day prior to going into the OR. And so they really need to understand what the long-term plan is for the patient and the bed space plan for the patient and things. So they tend to document this a little better than I find that my surgical team does. Now, this is going to vary by programs, but it's just understanding how your program may approach something. I've had this similar scenario with patients, and some of them are planned Norwoods and some of these are unplanned Norwoods. So there's no way to just look at this and say, oh, we always do this or always do that. I also would like to highlight that if your program says things like, we would plan to do, if procedure X fails, then we will plan to do Y. That does not make that reoperation planned. Because of course we would plan to do anything after a procedure fails, or we would always plan to do CPR should you have a cardiac arrest. It doesn't make the CPR planned. And so staying away from that kind of logic if you see that documented, because of course we would all rescue if a certain procedure fails. We would plan to do the next procedure. Does not make the next procedure planned. Okay, so next slide, please. Post-Norwood, the patient returns to the ICU intubated with an open sternum. The following day, a mediastinal washout is completed as a part of routine open chest care. So is the mediastinal washout a complication? And this would be complication 22, an unplanned cardiac reoperation exclusive of the reoperation for bleeding. So would you say yes, mediastinal washouts are unplanned cardiac reoperations? Would you say no, mediastinal washouts are planned cardiac reoperations? Or no, because this is a part of routine care in this program? Or not enough information available to determine? Okay, Leanne, next slide. So the correct answer here is yes. Mediastinal washouts are unplanned cardiac reoperation. So even though they can be considered a part of routine open chest care at your center, you're still entering the mediastinum. It is still an event that has occurred post cardiac surgery and needs to be captured by the database. So these are considered unplanned cardiac reoperations. And so if you go to the next slide, Leanne, I pulled in the very long definition, but unplanned cardiac reoperation exclusive of a reoperation for bleeding is defined as any additional unplanned cardiac reop occurring after the time of OR exit date and time. And of course, a cardiac operation is one that is CPB cardiovascular or no CPB cardiovascular. We do have then a list of procedures that are always considered planned, such as delayed sternal closures, decannulation from ECMO or VAD or other mechanical circulatory support, and removal of catheters, versus those that will always be coded as unplanned. And so if you see here, there's many operations for or listing here of mediastinal explorations. And then of course, if there is bleeding, then it's always coded as bleeding requiring reoperation and not an unplanned cardiac reop. We get lots of questions about these to the core group, and we are very happy to always answer them. They help drive how we will write the definition in 6.23.2. So please always send those in if you can't answer your question based on the information that's already in the training manual. Next slide. The patient cannot tolerate oral feeds and requires G-tube placement. As a program, all neonatal families are counseled preoperatively for the potential need for G-tube placement post-cardiac surgery. So how is the G-tube placement handled in your complication section? Do you not code any complications for the G-tube placement? Do you not code any complications for the G-tube placement if the patient is a neonate, given this program does neonatal family counseling? Code unplanned cardiac reoperation or code unplanned non-cardiac operation. Give you a few seconds. Okay, Leanne, next slide. So the correct answer here is this is an unplanned non-cardiac reoperation or operation. Sorry, it's not a reop. And the thought here is, go to the next slide, Leanne. I'm sorry, I think I have the definition. Oh, I don't. silly me. So talking about the unplanned operations. So the plan for cardiac or non-cardiac reoperations must be clearly documented at the time of surgical planning for the index operation. So much like what the surgical plan was, for your initial repair, when you're looking at things like G-tubes or trachs following your index operation, there should, if it's going to be a planned trach or a planned G-tube, there should be clear documentation of that. Like, maybe perhaps general surgery or ENT is already involved in the case, and you have some type of severe comorbid condition affecting feeding or affecting your airway. And they say something along the lines of cardiac surgery will go first. And once the patient convalesces and recovers, then they will go on to have their trach or G-tube or whatever other non-cardiac reoperation is planned. But outside of that, it's not, you're not going to have planned G-tubes and planned trachs. I know that programs struggle with this. And so if you need to enter these and get a specific response from the core group, we're very happy to provide that. And, we completely understand that. And so, please submit your scenarios and your questions. I know this is difficult because, again, it goes along those, well, if a patient can't eat, of course, we're going to plan to put a G-tube in them. That doesn't make the G-tube planned as a part of their post-surgical care. Okay, next slide. Due to medical complexity, the patient is discharged to a chronic care facility on post-index operation day 50, and this is 20 days from the last cardiac operation. So 5 days later, after the patient is discharged to this chronic care facility, the G-tube falls out, the patient is readmitted for surgical replacement of the G-tube. So what complications are coded back on your index operation? Code unplanned readmission within 30 days of an operation. Code unplanned non-cardiac operation. Do not code any complications past post-op day 30, or do not code any complications post-discharge to the chronic care facility. Okay, next slide. So the correct answer here, a little tricky, is code unplanned readmission within 30 days of an operation because there was a CPB or no CPB cardiovascular, so cardiac operation. So that's the readmission occurred within 30 days of that. So you would also code unplanned non-cardiac operation because the patient undergoes surgical replacement of that G-tube. However, that's already coded for the initial placement of the G-tube, but you would not be wrong to have selected both, I guess, A and B in this scenario. So next slide, as we talk a little bit more about coding complications in this version of the database. You're going to code the complications for the time frame that is the longest. So through the 30th postoperative day or through the end of the episode of care, and this would be through the database discharge date. So a patient that stays in-house longer than 30 days, that would be their episode of care, and if they discharge home. However, if the patient were to discharge to another acute care facility or a chronic care facility, then that episode of care is extended and you're continuing to code the complications through that time point. There will be some caveats to this coming up in 6.23.2. So stay tuned. And of course, we'll get that information out to you. All right. So next slide. Same scenario. What is the patient's database discharge date? The date the patient initially transferred from the surgical hospital to the chronic care facility, the date the patient returned to the chronic care facility, or there's not enough information available to determine the database discharge date at this time. All right, next slide. So right now there's not enough information because as you recall, if we go to the next slide, I put the definition here. The database discharge date cannot be completed until one of the following is met. The patient survives on chronic care status for 183 continuous days. So that clock in this scenario would have started over when the patient discharged back to the chronic care facility. The patient discharges to home or the patient expires. So as of right now, the patient hasn't met any of this criteria. So we cannot complete the database discharge date. And I believe this is the last question. Next slide. Is this let me read the scenario, sorry. The patient returns to the chronic care facility and 3 months later, the patient experiences a cardiac arrest and expires. The cardiac surgeon says that this is related to poor staffing at the chronic care facility. So is this a surgical mortality? No, because the death was not related to the cardiac surgery. Or no, the surgeon stated the cause of death was unrelated to the cardiac surgery. Or yes, the patient expired in the chronic care facility at less than 183 days, or there's not enough information available to determine at this time. So next slide. So the correct answer is yes, this is a surgical mortality, and as the patient expired in the chronic care facility and they had not survived there for greater than 183 days. So I know, again, especially in the scenario where you have a patient that might come in and out of the chronic care facility. I currently, have had a patient for multiple years now that cannot survive the 183 days continuously on chronic care status. And I know it's frustrating. And at this point, there would be a lot of explanation back to the cardiac surgery program should the patient expire. And the patient's coming back for things like G-tubes and trachs and that kind of stuff, or respiratory illness. And they're very, very far removed from that cardiac surgery. However, because the patient has not yet met those 3 criteria, as we discussed on a previous slide, then I cannot fill in the database discharge date, and it would still be a surgical mortality despite being remote from the true cardiac surgery care or surgical procedure. All right, I think that's my last slide. Thank you.
Thank you, Chastity. Excellent presentation as usual. Next, I know Joe's got a super brief update, so I'm going to turn things over to Joe, and then we've got a couple of questions we can tackle. Joe, next slide's for you.
All right, great. Thank you, Leanne. As Leanne mentioned, this is a super quick update. Just a couple items that you see on this slide here. These are expected to be deployed and updated in early December, so sometime next month. The first one being for the primary procedure and case eligibility and mortality analysis reports, STS 8906. We will be adding the January 2019 through December 2022 date period to the drop-down selection for that report. I know some of you have reached out to us and mentioned that it's not available, so that will be coming soon. And then STS 8510 in regard to the participant non-analyzed dashboard report. We will be making updates for the stat categories to reflect the latest changes to Appendix C. So you can expect that to be updated next month as well.
Great. Thank you, Joe.
Thank you.
All right. That's all that we have. Let's see. As always, questions regarding any current reports that are out there already, just please reach out to tech support, CHSD tech support at IQVIA.com. And again, we're expecting the fall 22 reports to be available next month. And more specific, once we have more specific date, we'll communicate to you all. My contact information is here. If you need to reach out to me for anything, just shoot me an email. If you have any database operational questions, as always, just reach out to stsdb@sts.org. Upcoming webinars. So for next month, our next user group call, mark your calendar, scheduled for December the 6th at 12 p.m. Central. And then our next monthly webinar is scheduled for December the 20th at 12 p.m. Central. So mark your calendars accordingly, and we'll see you all on December the 6th. All right, it looks like we have some questions coming in chat. Most importantly, yep, everyone's like, thank you for the phenomenal education. All right, our first question from Deborah. I'm brand new to the STS program. I'm our PICU research coordinator and VPS database coordinator. Who should my lead contact be? I'm not sure, like, and I'm not in terms of STS contact or your internal contact. I'm not, if you could, I don't know if I'm understanding fully the question in terms of your lead contact. If you could just clarify, Deborah, if you have any questions, also you can feel free to email me directly for any STS related questions regarding the database. Again, feel free to email me directly. Chastity, looks like from Angie, can planned does not include if XX repair fails, will plan to YY be added to the training manual?
Yes, Andrea, absolutely. I'll be sure to add that in and update that because I know there's a lot of pressure on programs and stress on programs and things. And so as much clarity that we can provide regarding this is needed. So yes, Angie, absolutely.
Perfect. Thank you. Yep. And Carmen, I've got the slide back up for you with the upcoming webinars. There you go. Let's see. Next question. Can you go back to the slide about complications after discharge, but within 30 days of the last cardiac surgery? All right. Sorry for the angry scrolling. Jesse, let me know when I get
I
there.
know I'm trying to see which, I remember it's with
this one.
when the patient discharges, right? So maybe slide 23. Yes. So remember that you're coding complications as well as mortality within the 30 days of the last cardiac operation. And so I think a really good way to highlight this, Krista, is and this is how this rule came about. It is spelled out in the analysis overview, but it's like fine print, I feel like, and not something we think about often. And I know some of you have had some audits where a scenario like this has become important. But I had a case many years ago where a patient had their index operation. They decided to stay for a very long time because they loved our hospital food so much, and then had like a pacemaker procedure 4 or 5 months later, but went home within 7 days of that pacemaker procedure. So that pacemaker procedure was a no CPB cardiovascular operation. Again, the index operation was like 4 months prior. So the patient went home and ultimately during feeding had a cardiac arrest and died. So then I coded, of course, the date of the patient death and everything, but I did not include it as an operative mortality. And we never talked about it as an operative mortality because the index operation was 4 months prior. The patient had gone home 4 months later. And so all seemed okay. And then when I got my analysis report a few months later, this patient was selected as an operative mortality. And of course, I think there's an error and panicked. And instead, and it's clearly laid out in the analysis overview that the death occurred within 30 days of a no CPB or CPB cardiovascular operation. And so that was surprising and it makes sense, but just not inherent in my head thinking that would only go back to the index operation. And so that's not true. It's of any CPB or no CPB cardiovascular operation. And the same is true of the complications. And so if you have some specific questions, Krista, related to that, I'm happy to talk more about that.
Yep. Krista had a follow-up question. So so would you code complications to the end of the episode of care or just until 30 days after that last cardiac operation?
Oh, no, it's still through the end of the episode of care. Always the episode of care. The issue is that the patient had gone home, their episode of care you have an episode of care date. However, if there was a cardiac operation that hadn't hit a 30-day yet, then it would extend out to that, if that makes sense. It's a confusing situation and scenario. It doesn't come up often, but just I threw it in here because we get a lot of questions about this, and I think a lot of them are coming from audit, that people are finding it on audit, and so it's being explained then. So I thought I would throw it in here.
Right. She says, thank you. Gotcha. And Becky had a question. How do you code for a patient that was going for sternal closure, but the patient didn't tolerate chest not closed? So they just did a mediastinal washout. Is it planned or unplanned?
That's a great question. So if you're talking about the field, and I'm going to blank on the field number, is this a planned or unplanned procedure or unplanned reoperation? I would say it's a planned reoperation because we thought we were going to do the sternal closure. However, I would now call this failed sternal closure and just this mediastinal washout an unplanned cardiac reoperation on the complications.
Excellent. Okay. A question from Jen. This has to do with my quality improvement data requests. So they are currently suspended. I don't know if Carol has any input or knows any information about this. There's no clear date yet as to when the program will resume. We were not able to get data requests during the time IQVIA was trying to release reports. And now this, any idea when this will resume? Also, any talk about allowing more than one request per year? Carol, do you have any information about I know that's done through the STS Research Center.
I would, no, there's no date in 2022 when this will resume, hopefully in 2023.
Yeah, I don't have any other information regarding the research center.
I would reach out to Bonner. She's the one who's over the minor data requests.
Oh,
Or
perfect.
I think there's a link on the STS page regarding minor data requests. It is not done through the database side of,
Right.
it's done through the research center.
Right. Maggie, can you put the IQVIA update slide back up? So yes, here is that IQVIA slide. And Jen, I can get you, if you would like to reach out to Bono. I don't know if there's more talk about allowing more than one request per year. That would be a discussion for the STS Research Center side of things, as Carol indicated. Okay, that was from Bono. Okay.
I'll put the link for the research center minor data request in the chat box.
Okay. Perfect. Thank you.
And it looks like we have another contact person for that. So
Okay, great. Thanks, Maggie. You're welcome. All right. While we're waiting for additional questions, I just wanted to, we had some sad news this morning come through the STS, just to alert everyone. Our STS is saddened to announce the sudden passing of our immediate past president, Dr. Sean Grondin. So Dr. Grondin was a thoracic surgeon at Alberta Health Services and professor of surgery at the University of Calgary, Cumming School of Medicine in Calgary, Alberta, Canada. So he was our president of the STS in 2021. So we're just really heartbroken and devastating news out for STS this morning. So we just ask that you keep his family, his colleagues, his friends, everyone, all his direct family members in your thoughts and prayers. So just sad news coming out this morning for STS. All right, I don't see any additional questions. I know Dr. Meyer and Dr. Subramanian are on. I don't know if you all had anything you needed to share prior to closing. Right.
Nothing more from me either, more than just thanking Chastity for another outstanding session and all the data managers for their strong participation.
Yes, thank you all. All right, just a reminder, our next webinar is the user group call on December the 4th at 12 Central, and our next monthly webinar is scheduled for December 20th at 12 Central. Again, Chastity, thank you for phenomenal education. We appreciate you. Thank you so much. And thanks everyone for joining today, and we will see you on our next call.